The talk that I'm giving today was originally presented at the South Asia Regional Conference on Addressing Wasting, which was held in Kathmandu and hosted by UNICEF. So I want to move on now to share just a few examples of implementation research in nutrition that we've done. The Society for Implementation Science in Nutrition has a nice classification scheme of where to place implementation research, and it relates to the objects of implementation lined up around sort of the phases of implementation, if you will. So most of our work, as you can see in this particular table, the Alive and Thrive work, for example, it cuts across the continuum of implementation, and it's really quite focused around nutrition-specific interventions. But through the course of this particular program of work, there's research that has come out of the initiative that touches all of the different phases of implementation research. And the work that our group has done in particular, though, has been around really the implementation, iterative improvement, and scaling up through the work we've done on the impact and process evaluations. We've also done the work that we've done in Bangladesh, with the National Nutrition Services and with an operational assessment in India, are also more focused on the nutrition-specific interventions and on implementation. So these are just the examples that I'm presenting today. Across our research group, however, we've been doing work that cuts across several different parts of this particular classification system, but there's obviously no time to go into all those. So the first example I want to share with you is results from the impact evaluation that we've done, with the evaluation work that we've done on Alive and Thrive. And this work has all now been published and is available to access. What you see in this graph is the impacts of the intervention, which was really this intensive interpersonal counseling, which was delivered through very different delivery platforms in the 3 different countries. And what you see here is the impacts of that on exclusive breastfeeding in the 3 different countries that we worked in. So what you see here is that, firstly, the solid bars there are all the intervention areas. The dotted lines are the change over time in the control areas. And what you see is that in the 2 countries where we had control groups, you see very similar patterns of improvement in exclusive breastfeeding over time in the intervention areas, with very little change in the control areas. In Ethiopia, which is the dark blue line on top, we did not have a control group in the evaluation. So what you see is just the change in the intervention areas. Now, at first look, you see already that the starting points for exclusive breastfeeding, which is the figures on the left side, saying baseline 2010, are very different in the 3 different countries. And where they reach at the end of the interventions is also really quite different. And our interpretation is that the results on the impact are were quite driven by the overall context for where the countries were at baseline, but also by the context for implementation. For example, in Bangladesh, the intervention was delivered through an outreach program that achieved very high reach, close to 95% reach of the interventions, and it was reaching communities where the women were not working outside of the homes, which is why we think we are seeing results that are as high as they are in terms of achieving exclusive breastfeeding rates of close to 90%. In Vietnam, on the other hand, exclusive breastfeeding was very low at baseline, driven by largely a context of women being out at work very early, a lot of aggressive marketing by formula companies. And what you see over time is that the intervention did manage to mitigate some of those challenges, but the achieved levels of exclusive breastfeeding, they tripled, close to tripled over time, but are still around the 60% mark, which means that there's still some room for improvement. In Ethiopia, exclusive breastfeeding was fairly normative and stayed. There was some improvement over time. We are really unable to assess from the kind of work that we did whether it was fully attributable to the interventions. Now, what you see on the impacts on complementary feeding is that the Ethiopia and the Vietnam lines are somewhat flipped. In Ethiopia, which is the line at the bottom, the complementary feeding, this is dietary diversity, was very low at baseline. It almost doubled over the course of the implementation of the intervention but is still very, very low at 12%. And the research, the implementation research in particular that we've done, really seems to indicate that overall household food diversity is a huge challenge to achieving minimum dietary diversity in the context of a place like Ethiopia. In Vietnam, which is the lines on the top, it was already high at baseline. So, already 75% of children were achieving minimum dietary diversity. And there was a change over time that was not differential between the intervention and control areas. Whereas in Bangladesh is where we saw the maximum intervention impact, where minimum dietary diversity almost doubled over time. Again, though, they're achieving, unlike the breastfeeding results, coming to about 65%, which means, and our qualitative research and other components of and our analysis of the quantitative data suggests that in Bangladesh too, there were significant household resource constraints, which is why despite a 95% reach of the interventions, you don't see adoption of minimum dietary diversity in all of the households. Now, in looking at the results together for these three countries, as I mentioned earlier, we had very different, sort of the same kind of intervention, but very different implementation contexts. So in Bangladesh, it was outreach through an NGO platform that achieved very high reach, along with a national television-based mass media campaign. In Vietnam, it was a facility-based set of counseling services, which meant that the families had to come in and use the facilities. And that in itself leads to some demand constraints. And then there too, there was a national TV-based mass media campaign. In Ethiopia, the outreach was through the government's multi-purpose health workers, and the mass media was through radio spots. So if you then look at the reach of the intervention, which is the graph that you have in front of you, with the knowledge of what these implementation contexts look like, and what implications that had for use of the platforms by client populations, you start to understand why, for example, we see very different pictures in terms of exposure to the interpersonal counseling in the previous 6 months among mothers of children 0 to 5 months of age. So in Bangladesh, where it was outreach based, it was very high. So we knew that 86% of mothers had been reached with the intervention, and a slightly lower percentage had been exposed to the mass media. In Vietnam, the pictures is actually a little bit flipped, because the exposure to interpersonal counseling required that people come into the clinic. So there was a clear demand side constraint there. Whereas the mass media campaign, which is the light green, did not have really any demand side constraints. And so there you have that. And then in Ethiopia, the health system itself has been evolving over this time, and you have a set of health workers that are executing multiple activities, multiple interventions, including immunization, family planning, and all kinds of other things. And therefore, the reach of the nutrition counseling itself was not as high as it could be in a place like Bangladesh, where they were able to really deploy a stable outreach platform. So from the work in Alive and Thrive, what we were able to take away from this, and we are still synthesizing some of that, is that this combination of a core intervention, which was around interpersonal counseling, but in three very different kinds of implementation contexts, and alongside that, three really different contexts for uptake of the interventions, leads to very different pictures in terms of both the overall impact, but also the reach of the interventions. In Vietnam, sorry, this is just adding to the Vietnam story. What we found was that even though there was a high level of awareness of the logo and high awareness of the use of the platform itself, only 50% had actually ever been to that particular platform. So that's the two graphs in pink. I'm moving on to a second set of interventions, a second set of research that we've done. This has been work that we've been doing under the Poshan initiative, and this particular graph will look very familiar to you. It's the same kind of coverage graph that looks at the scale and the reach of the interventions. And what I want to point your attention to is firstly how high the coverage. We found very high coverage of interventions during pregnancy, a bit of a mixed picture in the first 6 months, and then a much more variable picture of coverage in the 6 to 24-month period. Now, the bar and graph there is what's relevant to the topic of the seminar, which is on implementation research in the context of wasting prevention and treatment programs. And what you see there is that despite very high reach of many other interventions, only about 50% of children had their growth monitored. Now, if you think about something like screening and treatment, treatment for severe acute malnutrition, your screening is the first entry point. And if you have only 50% of children being screened through growth monitoring clinics, that sets the tone or the pace for whatever comes after that. So a key goal here for something like treatment protocols or establishing treatment protocols would be to bump the coverage of growth monitoring for screening into these programs up as close to 100% as possible. Now, what's interesting in the context of India is that Orissa is actually one of the better performing states on something like growth monitoring, and the National Family Health Survey, which is the last published data available, shows that across India, only 18% of children had their weight measured in these Anganwadi clinics, which is the clinics, the community centers where they do this work. And Orissa, which is the state where we did the work, is the only state where more than half the children were actually weighed. So what this says is that, for India in particular, just getting the screening to be close to 100% in and of itself is a really important entry point for any of the other work that then needs to happen looking forward for establishing protocols for severe acute malnutrition. And this particular piece of work, which was a very simple operational assessment, but looked very carefully at the coverage and the reach of these multiple services across the first 1,000 days, is a really, for us, was a neat example of a diagnostic type of implementation research study that has then led forward to many conversations with people in the implementation landscape in this particular state on the kinds of things that could be done to strengthen the reach and coverage of these services. The last example that I want to speak about today is work that we've done under to look at, again, this was a one-time operational assessment, so very different from the work we did on Alive and Thrive. It's a one-time operational assessment of the national nutrition services in Bangladesh, where the government of Bangladesh has basically started to integrate or mainstream nutrition-related interventions into their routine health systems. So what we did was um, do observations of the delivery of these nutrition interventions in the context of health systems. So in this particular slide and the related paper uses data from over 500 case management observations of sick child care. And the idea in Bangladesh was that in the context of sick child care, the providers at the government health clinics were expected to do several different things related to nutrition, such as weighing and recording their weight and height, doing a clinical diagnosis for severe acute malnutrition, demonstrating and providing some counseling on exclusive breastfeeding or other aspects of IYCF. And we found this to be a really challenging. What we found was that providers were weighing and recording the weights of children in these sick child contexts, but were actually not doing most of the other things that they were expected to be doing as part of the mainstreaming. Um, and a key challenge there was just simply the caseload. Providers who are looking after sick children in these clinics were actually had very high caseloads and had very little time with the children that they were seeing, and so they really were sharply prioritizing and just doing what was most critical in the context of sick childcare, which is weighing and recording the weight, because they really needed that to prescribe antibiotics or other treatment for these children. The government of Bangladesh has since then really started to revamp, since this assessment was done, has started to revamp and improve the protocols and examine these things. We have some more collaborative work going on with ICBDRB, so I'm hoping that we'll see what this looks like in the coming years. So just to close out this part, reflecting on these implementation research studies we've been involved in. Firstly, on the intervention side of things, it's very clear that the challenges of delivery and of doing research around those vary tremendously by intervention type. Even seemingly simple interventions like nutrition counseling or delivery of supplements can have some very significant systems and capacity needs. A big issue around scale is that somehow addressing demand side constraints is really important. And both in the Bangladesh example and in the Alive and Thrive Vietnam example, we see that facility-based delivery platforms have significant demand side constraints. People don't necessarily come to the facilities, especially for preventive care. And when they come, they're not necessarily demanding some of these more preventive-based nutrition services. In terms of delivery platforms itself, certainly, what we are seeing is that the reach and the maturity of the platform itself is critical. If I think about the differences between what we saw with the reach of the interventions in Bangladesh versus in the Ethiopia context, in Bangladesh, the delivery systems had been well established for many, many, many years, and integrating nutrition into that was not as challenging as in the context of a more evolving health systems platform in Ethiopia. But even within the same kind of platform, the ability to assure the quality and the intensity really differs quite a bit by context. We are continuing to do a lot of work still in the Alive and Thrive system, and are seeing that even in the context of robust delivery platforms, very significant investments are required in monitoring and incentives and strengthening overall systems capacity. So really, we're learning a lot from the three examples that I've shared with you, but the much larger portfolio of implementation research that our research group has been involved in. What does this mean? What does this way of thinking about implementation research mean in the context of thinking about prevention and treatment of wasting in South Asia is the last question that I'm asking in this. And um, the way that I'd like to put that forward is to say, firstly, we have to think about this continuum of prevention to treatment for wasting, and to think about all the steps that have to be in place in along this continuum, and identify then the key areas of research that are needed to help um, get this continuum working well. So the first component, of course, is the prevention aspect, and there needs to be some very, very significant thought. These are just illustrative questions on what research needs to be done to really answer the questions of how to effectively deliver the preventive actions to address undernutrition at scale, and what platforms work best to reach children, mothers and children, with these services. The next set of things is very specific to uh, the screening and treatment for wasting. So the first part is, of course, the identification, and there is a whole host of implementation research that really needs to be done to understand what platforms and approaches can be integrated in ways to support effective screening and identification. How do you get the screening to be up to 100% when you have these community-based platforms in place? It's no use if all we are doing is screening 50% of the kids or 25% of the kids, if what you want is to be able to identify and reach solutions to all of them. What metrics, for example, weight for height versus weight for age versus MUAC, are most feasible and effective to integrate into existing delivery platforms from the perspective of frontline workers and mothers, to ensure that you're able to easily um, screen on a routine basis, um, and identify children who are severely malnourished. Then there's a whole host of research questions around treatment. What are the best treatment modalities? How do you match treatment modalities to context? Um, how do you really integrate treatment with prevention? How do you motivate and support the frontline staff who deliver these programs? The context in South Asia is there are some emergency contexts and there is a seasonal aspect of it, but we really have a situation with very large numbers of and some sort of underlying chronic conditions that seem to precipitate severe wasting. How do you deal with the treatment situation in that context versus in another context where you're in refugee centers and you're doing more um, um, emergency type of treatment protocols? Um, and particularly in this sort of chronic wasting situation and non-emergency setups, how do you also integrate in ways that prevent relapse? So what kind of research do you need to do to understand how best to set up supportive systems that prevent relapse? What are the most feasible graduation criteria for children in these programs? How do you do the follow-up work to continue to screen and make sure that children aren't falling through the cracks? So there's a whole continuum of issues here, and and then of course there is the question of costing studies that have to be integrated with all of this, so that you're able to see how best to make use of the resources that are really available. There's a whole implementation research agenda, therefore, that needs to be developed in the context of this continuum of prevention and treatment of wasting in places like South Asia, where we are dealing with a very different context potentially for wasting than in other emergency settings. So in closing, I just want to say that firstly, there are tremendous opportunities and there is a huge need to invest in understanding how to support effective interventions across this continuum of prevention and treatment of malnutrition. For people that are really engaged in this from an implementation perspective, it's really quite important to start to articulate the implementation research questions that lie around this, because this kind of research, which is embedded with the different systems of intervention delivery across the region, can really help to identify ways to strengthen delivery. Um, and the key areas for wasting focused implementation research will really have to be around integration with prevention, screening and identification, development and validation of coverage measurements, understanding issues related to uptake and adherence, prevention of relapse, and so much more. So again, I just want to thank you um, again for this opportunity, both to UNICEF for the opportunity to put together these thoughts, and to the Society for the opportunity to do this webinar. There's quite a lot of good reading on the need to link wasting and stunting um, from a symposium almost 5 years ago on building convergence in science programs and policy on under nutrition. So I would recommend that as some further reading here. I'd like to acknowledge several research collaborators who I've been working with over the last several years. With that said, thank you very much.